1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
I want you to imagine a medical intervention that takes exactly 10 minutes.
Just 10 minutes.
Right. It doesn't require a sterile field or, millions of dollars in robotic surgery equipment.
No advanced labs needed either.
Exactly. But this 10-minute intervention has the power to completely invert the failure rate of a life-saving medical treatment.
I mean, it sounds like hyperbole, I know, but it is one of the most stunning pieces of evidence in the source material we are unpacking today.
It really is. So picture this. Researchers took a group of children and adolescents who were just starting on a new psychiatric medication.
And they split them into two groups.
Right. Both groups get the pills. But for the intervention group, a nurse makes a really short, 10 to 15-minute phone call to check in.
Just checking in on day 1, day 10, and then at the 1, 2, and 3 month marks.
That's it. Just a quick, hey, how are things going?
And if you are a healthcare learner, whether you're a nursing student studying for your boards, a resident, or an active practitioner, this is exactly the kind of high-yield data you need to pay attention to.
Absolutely.
Because the results completely shatter the traditional biomedical model.
Yeah, let's look at those results. At the 3-month mark, the control group, the kids who just got the pills and standard care, they had a 93% failure rate.
93%. That is massive.
Right. 93% had low medication adherence. They were barely taking the meds at all.
But then you look at the intervention group.
The ones who got those few short phone calls, 96% of them had high adherence.
Oh, wow.
They were taking their medication exactly as prescribed. A few brief moments of human connection took a 93% failure rate and flipped it into a 96% success rate.
Which proves a really fundamental truth about mental health care.
Yeah.
Handing a patient a prescription is not healthcare. Healthcare is ensuring the patient feels supported enough and connected enough to actually take it.
And that completely upends how we are usually taught to think about medicine.
Oh, completely.
Because usually there's this expectation of precision. You break your arm, the x-ray shows that jagged white line, and the doctor points at it and says, there it is. That's the problem.
Here's your cast.
Exactly. You get a cast, you wait 6 weeks, you are cured. But when you step into the world of mental health, that x-ray machine is broken.
Yeah, we are looking at a diagnostic and treatment landscape that is not a straight line from pill to cure.
Mm-hmm.
It is a wildly complex, fragile web.
It really is.
It is entirely systemic.
Mm.
If you want to understand the modern reality of psychiatric care, if you want the 20% of knowledge that gives you 80% of the clinical understanding, you have to look beyond the clinical pathophysiology.
You have to look outside the hospital walls.
Precisely.
So, that is our mission today. We are taking a massive deep dive into the evolution and, frankly, the stark reality of modern mental health systems. It's a lot to unpack.
It is. If you want to know how a patient's zip code impacts their recovery more than their actual diagnosis, or why our emergency rooms and prisons have become our primary psychiatric holding facilities, you are in the right place.
But to understand the chaos of the system we have right now, we kind of have to look at the system we dismantled.
Right. We need to go back to the 1950s.
That is the essential starting point for any practitioner. Because prior to the 1950s, if you had a chronic, persistent mental illness, the standard of care was simply containment.
Just locking people away.
Basically, you were placed in a massive state facility.
Yeah.
And we aren't talking about a brief stay here.
Right.
People lived in these institutions for years, decades, sometimes their entire adult lives.
But then the 1950s happened, and psychotropic medications are introduced.
And this wasn't just a clinical breakthrough, it was a systemic earthquake. For the very first time, there was a tangible way to manage symptoms that were previously considered completely intractable.
Psychotropics brought the first real hope for meaningful sustained treatment.
So suddenly you have these massive state hospitals filled with people whose symptoms are actually becoming manageable.
Yes.
And right as that clinical shift is happening, society itself shifts. We hit the 1970s, and the culture starts demanding a total reevaluation of civil rights.
Exactly. The 1970s ushered in these sweeping legal changes regarding involuntary commitment. The guiding legal and ethical principle became the mandate for the least restrictive environment.
Which, on its face, sounds incredibly humane.
Oh, absolutely.
It sounds like exactly what we should be doing.
It was brilliantly intentioned. The legal consensus was that institutions could no longer indefinitely hold individuals against their will if their symptoms could be managed elsewhere.
Right.
So the policy of deinstitutionalization began. The state hospitals emptied out.
And what was the vision there?
Well, the grand vision was that clients would return to their communities, live in their own neighborhoods, and receive robust, localized outpatient support.
But if you are working in healthcare today, you already know the punchline to the story.
Unfortunately, yes.
There was a catastrophic catch.
A monumental one. We call it the funding gap.
The funding gap.
Yeah, the system successfully dismantled the institutional infrastructure, but it entirely failed to fund the community infrastructure meant to replace it.
Oh, wow.
We emptied the hospitals, but we never built the safety net to catch the people walking out the doors.
Which leaves us with the system we have today. You know, a system where the rules of the game are almost entirely dictated by managed care economics.
Right. Today, managed care utilizes really intense cost control mechanisms. You see constant recertification for admission, utilization reviews, and strict case management.
It's all about the bottom line.
Exactly. The entire economic structure of a hospital is now built around brevity.
I was reading through the source materials about what inpatient units looked like back in the 1980s before managed care totally took over.
Oh, milieu therapy.
Yes. They used this model called milieu therapy, which blew my mind because it sounds so fundamentally different from a hospital ward today.
Milieu therapy is a fascinating concept for any student of psychology. It's the idea that the total environment,
The whole vibe of the place.
exactly, the physical space, the social structure, the daily routine, that is the treatment. It relied on one-on-one therapy, group trust exercises, and deep self-disclosure.
Wow.
But here is the critical systemic requirement for milieu therapy. It demanded very long hospital stays.
Because to have a therapeutic community, you actually need time to build a community.
Precisely. You needed clients who'd been there for a month, whose symptoms were stabilizing, to act as mentors.
Oh, that makes sense.
They provided structure for the clients who were newly admitted in acute distress. The stable patients essentially helped regulate the environment.
But keeping a stable patient in a hospital bed for weeks just so they can mentor someone else?
You wouldn't fly today.
Great. I can practically hear a modern insurance executive screaming about the cost.
And that is exactly what killed the model. Managed care deemed it prohibitively expensive. So today, the system has driven down admission rates and drastically slashed the length of stay.
Which creates a terrifying reality for bedside nurses.
Oh, absolutely.
Because if you only admit the absolute most critical cases, and you kick them out the second they aren't actively dying, the acuity on that floor, the overall sickness level, is astronomical.
It is a pressure cooker.
Right.
Today's inpatient unit is solely focused on rapid assessment, rapid stabilization, and immediate discharge planning.
Okay, let me make sure I'm wrapping my head around this paradox, because it sounds like a trap.
It is.
We penalize hospitals financially if a patient bounces right back and gets readmitted.
Right.
But the financial system itself is starving the hospitals, essentially forcing them to push sicker, more unstable people out the door faster than ever before.
You have perfectly identified the core contradiction of modern psychiatric care. It is a financial model demanding clinical miracles on a stopwatch.
A stopwatch.
Yeah. And if you understand that, it completely reframes how you view those first few hours of a patient's admission. It explains why the modern clinical team isn't focused on deep psychological breakthroughs.
Because they can't be.
Right, they are running a race against a managed care clock.
So we've gone from months of therapeutic community building to a drive-through stabilization model.
Drive-through is a good way to put it.
You get in, we stop the immediate bleeding, and we push you out. And the physical environment they do this in is intense. We are talking about locked doors.
Yes. Most acute psychiatric units are locked, requiring staff to physically key in and out. And this creates a profound dichotomy that every psychiatric professional has to grapple with.
How so?
Well, on one hand, you have the absolute necessity of safety. For a patient experiencing severe psychosis or acute suicidality, A locked unit provides a necessary, secure perimeter against the overwhelming stressors of the outside world.
So it's a sanctuary.
But simultaneously, it is a prison. A locked door fundamentally strips a patient of their autonomy.
Wow, yeah.
It emphasizes the massive power imbalance between the staff who hold the keys and the patient who does not. It can induce feelings of confinement and dependence.
Which is exactly the kind of restrictive environment the 1970s legal reforms were trying to abolish.
Exactly.
And honestly, that's if a patient is lucky enough to even get behind those locked doors. Because the system is so bottlenecked, we have this terrifying phenomenon called boarding.
Boarding is one of the highest risk scenarios in modern medicine. When a patient goes into a psychiatric crisis, they typically go to a standard emergency department.
Right, the ER.
And because psychiatric beds are so incredibly scarce, these individuals end up boarding in the ED. They wait on gurneys and hallways, sometimes for days.
Days.
Yes, hoping to avoid a formal admission or waiting for a specialized bed to finally open up.
Put yourself in that scenario for a second. You are experiencing the worst mental health crisis of your life. Your brain is lying to you, you might be hallucinating, you are terrified. And your healing environment is a loud, chaotic emergency room with trauma alarms blaring, fluorescent lights, and zero privacy. That doesn't just stall recovery, that actively traumatizes the patient further.
It exacerbates every single symptom.
Yeah.
When they finally do get a bed, as we noted, the discharge clock is already ticking.
Which brings us to a piece of data from the sources that fundamentally changed how I view this entire field.
The discharge plan data.
Yes. It said that the adequacy of a patient's discharge plan is actually a better predictor of how long they will remain successful in the community than their actual psychiatric diagnosis.
I want every listener studying for their clinicals to engrave that concept into their brain. Let me restate it. The environment a patient is discharged into is more predictive of their long-term survival than the specific biology of their illness.
That is staggering. It means that the social worker arranging housing is arguably performing an intervention just as critical as the psychiatrist prescribing the lithium.
Without question. You can perfectly dial in a medication regimen for a severe, persistent mental illness. But if you discharge that patient to a park bench, the clinical intervention will fail.
Right.
Conversely, a patient with incredibly challenging symptoms who is discharged into a highly resourced, structured, and supportive environment has a remarkably high chance of stabilizing.
But here is where the system completely fails its own logic. If the discharge plan is the literal key to success, why aren't we giving everyone the gold standard?
It's a great question.
Why did the sources spend so much time talking about patients leaving with what they called marginal discharge plans?
Because the system operates like a series of sieves, and the mesh gets wider and more unforgiving, the more vulnerable the patient is.
What do you mean?
Well, the sources explicitly outline the barriers to a good discharge plan. Things like active substance use, a history of criminal behavior, non-adherence to past treatments, or ongoing suicidal ideation.
So if you have any of those things in your chart, the good doors lock.
Exactly. High-quality group homes or supported apartments simply will not accept a patient with a recent history of violent behavior or active drug use.
Yeah.
Their insurance liability won't allow it, and they don't have the staff to manage that level of acuity.
Think about how twisted that is. The system looks at the highest risk patients, the ones whose illnesses are causing them to self-medicate with drugs or act erratically, and says, sorry, your symptoms disqualify you from receiving the environment that cures your symptoms.
It's a devastating paradox.
So they get a marginal plan, which is essentially a fast pass right back to the emergency room.
It's a self-fulfilling prophecy of readmission. And even when we do secure a decent outpatient referral, we have to consider the human element of trust.
Right.
A patient won't go to a follow-up appointment if they feel no connection to the provider.
So you can't just slap a sticky note with a clinic address on their discharge papers.
No. High-yield nursing practice requires anticipating exactly why a patient will fail to follow up. Does the patient trust this clinic?
Is it even accessible?
Right. Have we involved their family? And most importantly, have we established relapse prevention education?
Relapse prevention. What does that actually look like when you are sitting in a room with a patient?
It means moving away from abstract concepts and getting hyper-practical. You teach the patient and their family to recognize the tiny, subtle dominoes that fall before a full crisis.
Like early warning signs?
Yes. You help them identify their specific symptom triggers. You build a rigid daily structure so that unstructured time doesn't lead to rumination.
Oh, that makes sense.
A patient who knows exactly who to call when their sleep pattern changes for 2 nights in a row is a patient who avoids the emergency room.
So if the discharge plan is that critical, what happens the day after they leave the hospital? Where do they physically go to get that structure if they aren't ready to live entirely alone?
That is where the bridge programs come in, the most prominent being partial hospitalization programs, or PHPs.
The sources broke these down into day programs and evening programs.
Yes, they are designed to be the stepping stone. In a day program, the client spends their day at a clinical facility receiving intensive, structured treatment, but they go home to sleep in the community.
And evening programs are just the reverse.
Exactly. Evening programs flip that, allowing clients to attempt daytime work or school while still receiving intensive daily support.
And what are they actually doing in a PHP? Because it's not just a drop-in center where people watch TV.
Far from it. It is highly regimented. They are stabilizing symptoms in a real-world context. They are monitoring drug efficacy when the patient is actually out dealing with traffic, family, and society.
Real-life stressors.
Right. They run groups on problem-solving, communication skills, and extremely practical daily living strategies.
But the PHP only works if you have a safe place to sleep at night. And the residential housing landscape is wildly diverse.
It is a massive spectrum.
Yeah.
On one end, you have boarding care homes. This is minimal supervision, like a room, a bathroom, maybe laundry facilities, and one communal meal a day.
And then you have adult foster homes, which really surprised me. I always associated foster care with children.
Adult foster care is an incredible model. It places 1 to 3 adult clients into a family-like atmosphere.
Oh, wow.
Yeah, they share meals, chores, and social activities with a host family, providing immense social modeling. Then you have halfway houses, which are temporary, transitional placements, and group homes, which might house 6 to 10 residents with 247 staff supervision.
I was reading about a strategy used in Canada and Scotland called the transitional relationship model to help patients move into these homes, and it addresses the exact issue of trust we were just talking about.
It is a brilliant psychological intervention. It utilizes 2 components: peer support, meaning connecting the discharging patient with someone who has lived experience and is already succeeding in the community,
That's huge.
and, crucially, bridging staff.
Right. I loved this concept because usually when a patient leaves a hospital, the hospital nurse says, "Good luck," the doors close, and that relationship is dead.
Just severed completely.
The patient is thrust into a terrifying free fall until they meet their new community provider.
But with bridging staff, the hospital staff deliberately overlaps with the community team. The inpatient clinician does not terminate their relationship with the client until a solid, trusting bond has been established with the new community provider.
It is a warm handoff.
Exactly. It transfers the trust the patient has built in the hospital directly to the new team.
It makes so much sense. But even if you have a warm handoff, and even if you find a great group home, there is a massive, crushing weight sitting on top of all of this.
The financial piece.
Yes, and we have to talk about it because you can't talk about mental health systems without talking about poverty.
Poverty is the silent architect of almost every mental health crisis. Clients with severe mental illness frequently rely on government entitlements, specifically Supplemental Security Income, or SSI.
Do you know what the average monthly income from SSI is according to the sources?
It's shockingly low.
$400 to $450 a month.
It is an economic impossibility.
I want you, listen to this, to run that math in your head right now. Try to build a life in any city in this country on $450 a month. Rent, food, transportation, clothes.
You literally cannot survive.
So the obvious question people ask is, well, why don't they just get a part-time job to supplement it? Bag groceries, do something vocational.
And many clients desperately want to work. But here is the systemic trap, the economic cliff edge built into our policy, the disincentive to work.
This is so infuriating. Walk us through the hypothetical scenario of a patient trying to do the right thing and get a job.
Let's say a patient stabilizes, they're feeling empowered, and they take a low-wage, unskilled, part-time job. The moment their income crosses a very low threshold, they don't just lose their SSI check.
Which is bad enough.
They risk losing their Medicaid.
They lose the health insurance that pays for the thousands of dollars of psychotropic medication keeping them stable.
Exactly. So the system forces a completely rational human being to make an impossible choice. Stay unemployed and live in crushing poverty, but keep the medication that keeps you alive. Or take a minimum wage job with zero benefits, lose your life-saving medication, and inevitably end up back in the locked psychiatric ward.
It is economic sabotage. The system literally punishes them for trying to integrate.
It does.
And society punishes them too, especially when it comes to where these group homes are located. We have to address NMBY.
NMBY, not in my backyard. It is a powerful, highly destructive sociological force. When an agency attempts to open a group home in a residential neighborhood, the local residents frequently organize to block it.
Because they're terrified.
Driven entirely by stigma and misinformation, they argue property values will plummet. They operate on the deeply ingrained stereotype that people with mental illness are inherently violent or a danger to children.
Think about your own neighborhood for a second. If a notice went up on a telephone pole saying a 6-bed psychiatric group home was opening next door, how would the community board react?
They would lawyer up.
They absolutely would lawyer up. But what is the clinical consequence of that? If the quiet, well-resourced neighborhoods block the housing, where do the patients go?
They are forced into industrial zones, commercial strips, or neighborhoods with extreme crime and poverty rates.
Wow.
And remember the rule we established earlier, the environment predicts the recovery. By forcing recovery housing into high-stress, high-crime areas, NMBism directly sabotages the clinical outcomes of these individuals.
It's just staggering. The odds are stacked so incredibly high. Which brings us to a major shift in how we even define what a good outcome looks like.
Right, shifting the goalposts.
Because if you go through all of this, the hospital, the group home, navigating the poverty trap, what are you actually striving for? In the rest of medicine, you are striving for a cure, but here
you have to fundamentally change your vocabulary. This is a vital concept for our learners. You must distinguish between cure and recovery.
I really liked the pneumonia analogy from the sources for this.
Yes, the biomedical model of a cure is like treating pneumonia. You have an infection, you take a targeted course of antibiotics, the bacteria is eradicated, and you return to your baseline state.
You are cured.
Exactly. The disease is gone forever.
But severe mental illness does not operate on an antibiotic model.
Not at all. Psychiatric rehabilitation focuses entirely on the concept of recovery. Recovery is the ongoing, continuous management of a chronic, potentially recurring condition.
So it's management, not eradication.
It is a lifelong pursuit of optimal wellness, not the eradication of the underlying vulnerability.
It's not just taking a pill so the voices stop.
No, symptom control is just the absolute baseline. True recovery is about personal empowerment, finding meaningful social roles, gaining independence, and improving your quality of life.
It sounds so human.
The goals of late-stage psychiatric recovery are identical to normal human aspirations: having friends, having a purpose, and valuing yourself.
It's like the difference between going to a mechanic to swap out a broken alternator. That's the cure model. It's transactional, it's fixed. Versus joining a lifelong vintage car club. You know the engine is always going to be finicky. You know it requires constant, careful maintenance.
I love this analogy.
But you do it alongside a community of people who are all sharing tools, sharing advice, and focusing on the joy of driving, not just staring at the broken parts.
That is a phenomenal way to conceptualize it. And that car club analogy maps almost perfectly onto one of the most successful, radical models of psychosocial rehabilitation ever created: the clubhouse model.
Yes, the clubhouse. This started way back in 1948 with Fountain House in New York City.
It is what we call an intentional community. The driving philosophy is that individuals with serious, persistent psychiatric disabilities can and will achieve normal life goals if they are simply provided with 4 core things:
What are they?
opportunity, time, support, and fellowship.
The sources listed the 4 guaranteed rights of a clubhouse member. I want to highlight these because they sound so simple, but they are revolutionary for someone who has been marginalized.
They really are.
Number 1, a place to come to. Number 2, meaningful work. Number 3, meaningful relationships. And number 4, a place to return to, meaning a lifetime membership.
Now, I want you to look closely at that list of guaranteed rights. What is glaringly absent?
There is nothing on there about medical compliance.
Exactly. And this is where the clubhouse model radically diverges from standard psychiatric care. Taking prescribed medication is not a condition of participation.
That feels so counterintuitive. Every medical instinct says, if a patient has a severe illness, our primary job is to ensure they take their medicine.
But the clubhouse operates on a different psychological frequency. They do not focus on the illness. They focus entirely on health.
Wow.
They fundamentally believe that members must ultimately make their own decisions regarding their treatment.
So what do the staff actually do? Just hang back.
The staff operate as partners. They help members secure housing or education, but they allow the members to maintain absolute autonomy.
That's a huge shift in power.
It is. It creates what is known as a rehabilitation alliance. By giving a patient complete respect, including respecting their right to refuse medication, you build profound trust.
And trust changes everything.
And remarkably, that exact trust is what eventually leads many members to choose to engage with their medications on their own terms.
You stop treating them like a broken machine that needs to be managed, and you start treating them like an adult.
You restore the dignity that the entire institutional system has spent decades stripping away from them.
Okay, so the clubhouse is a beautiful model for people who have the capacity and the desire to walk out of their apartment and go to the community center.
Right.
But what about the populations who can't? What about the patient whose paranoia is so severe they haven't left their room in 3 weeks, or the patient living under a bridge?
If the patient cannot come to the clinic, the system has to bring the clinic to the patient. And this brings us to one of the most vital interventions in the field, assertive community treatment, or ACT.
Also known as the Madison model, because it was created in 1973 by Marks and his colleagues in Wisconsin.
Right. These clinicians had a massive epiphany. They realized that trying to teach a patient complex community survival skills, like how to navigate a grocery store, how to use public transit, how to handle social friction,
Real life stuff?
doing all that while that patient is locked inside a highly artificial, sterile hospital ward is completely absurd.
The skills don't translate. It's like trying to teach someone how to surf by having them stand on a mattress in a locked room.
Exactly. The Madison philosophy was simple. Skills training must be done in the environment where the skills are actually required.
So what did they do?
They conceptualized a program that is essentially a mobile, 247 hospital without walls.
Let's break down the mechanics of an ACT team, because it is an incredibly resource-intensive model.
It mandates a very low staff-to-client ratio. You have an entire multidisciplinary team, a psychiatrist, psychiatric nurses, social workers, and vocational rehab specialists, dedicated to a capped pool of around 100 clients.
And the key difference from traditional case management is that they don't refer out.
That is the defining feature. A normal case manager acts as a dispatcher. They hand you a piece of paper and say, go see this housing agency on Tuesday and go to this clinic on Thursday.
Good luck.
Exactly. An ACT team provides almost all of those services directly. They drive to the patient, they meet them in their living room, in a fast food restaurant, or at a homeless encampment.
So if a client has a massive panic attack or a psychotic break at 2 in the morning on a Sunday, they don't call 911 and go to the emergency room.
No, they call the ACT team. The team is on call 24 hours a day, and the team physically deploys to the client.
That is incredible.
Furthermore, there are no artificial time limits. Once you're an ACT client, they commit to you for as long as the need persists.
And it isn't just an urban model. The sources mention that ACT has been successfully adapted for rural areas, which is fascinating because rural healthcare is notoriously under-resourced.
Rural mental health presents immense challenges. You have fragmented services, massive geographic distances, and often a much more concentrated social stigma.
Everybody knows everybody.
Exactly. In a small town, you can't anonymously slip into a mental health clinic. Everyone recognizes your car.
So how do they adapt it for rural areas?
They modify the structure, sometimes using two-person mobile teams instead of a massive multidisciplinary squad. But even with these limitations, the rural ACT adaptations produce incredible outcomes.
Like what?
Drastically fewer hospital admissions and greatly improved housing stability.
You know what strikes me about ACT? It's how it completely inverts the power dynamic we talked about earlier.
How so?
In the locked ward, the entire burden of conformity is on the patient. The patient must eat when told, sleep when told, and talk when told. But ACT flips the gravity. The system bends to the patient's reality.
That's a great point.
By removing the demand that a highly symptomatic person navigate 3 buses to sit in a sterile waiting room, you eliminate countless friction points that cause failure.
It is the ultimate reduction of barriers to care. And as we look at the evolution of meeting the patient where they are, we have to look at how technology has scaled that exact philosophy.
Which takes us to the digital frontier. Because if taking the clinic to a park bench is powerful, putting the clinic inside the patient's pocket via their smartphone is a whole new paradigm.
We were talking about information and communication technology, or ICT, telepsychiatry, telemental health, app-based monitoring.
Now, obviously, the COVID-19 pandemic forced everyone onto video calls, but the sources point out that while a lot of physical medicine has gone back to the office, telehealth and behavioral health has remained incredibly sticky.
It has.
Why is mental health specifically clinging to the digital model?
Because it solves the psychological barriers to entry. Yes, it solves the rural distance problem, but think about the clinical presentation of the illnesses we are treating. Imagine a patient with severe agoraphobia or debilitating social anxiety or a profound paranoia-driven mistrust of institutions.
The idea of walking into a sterile medical building, sitting in a waiting room with 10 strangers, and filling out paperwork.
It's too much.
That is an insurmountable mountain.
Telehealth allows that exact patient to engage with life-saving psychiatric treatment from the perceived safety of their own bedroom. It lowers the threshold of courage required to seek help.
Which brings us right back to that 10-minute phone call study we opened the show with.
Yes, the adherence study.
That wasn't just a neat piece of trivia, it is proof of concept. The digital tether, even something as low-tech as a phone call, provides enough perceived support to keep a patient engaged with their treatment.
It proves that presence, even virtual presence, is a potent medical intervention.
But as much as we celebrate ACT teams and telehealth, we have to face the dark side of this deep dive.
The gaps in the system.
Because despite all these innovations, the societal safety net is still full of massive, gaping holes, which leaves us with the two most vulnerable populations in our society, the unhoused and the incarcerated.
This is where systemic failure becomes catastrophic. Let's start with the intersection of severe mental illness and homelessness.
The sources use a specific phrase that I found really haunting: dual discrimination.
It is a devastating reality. People who are simultaneously homeless and living with mental illness face a compounded, unique brand of stigma.
How bad is it?
Studies have shown they report experiencing more societal discrimination based on that dual status than they do based on race or ethnicity.
Wow. And the clinical outcomes reflect that discrimination. Statistically, they are worse off in every conceivable category compared to unhoused individuals without mental illness.
Significantly worse. They spend much longer durations on the streets, they spend more total time in shelters, they have drastically less contact with family networks, and they face almost insurmountable barriers to securing employment.
So government initiatives try to step in. The sources highlight the PATH program.
Yes, projects for assistance in transition from homelessness. PATH is a federal grant program that funds outreach, case management, and community-based support specifically for this demographic.
Okay, that sounds like a good start.
It is. But there is a crucial clinical insight regarding homelessness that students often miss. Housing is not a cure.
That sounds backwards. If the problem is homelessness, isn't a house the exact solution?
A house solves the physiological need for shelter. But if you take a person with a severe mental illness who have been deeply traumatized by living on the streets, and you place them alone in an apartment without intense psychosocial support, they often remain profoundly, dangerously isolated.
They just go from being isolated in public to being isolated behind a closed door.
Exactly. They aren't integrated into a community. To truly impact their quality of life and ensure they don't lose that housing, they need peer support, relationship-building interventions, and daily structure right alongside the physical roof over their heads.
Because if they don't get that support and they remain on the streets, they are almost inevitably swallowed by the other massive system failure, the criminal justice system.
This is perhaps the greatest tragedy of modern mental health policy. The rate of mental illness in the prison system is estimated to be 5 times higher than in the general population.
5 times? How on earth did our county jails and state penitentiaries become the largest psychiatric facilities in the United States?
It is a well-documented sociological phenomena known as the criminalization of mental illness.
How did we get here?
It is the direct result of everything we've discussed so far. We emptied the state hospitals, we made civil commitment incredibly difficult to achieve, we starved community programs of funding, and we failed to create affordable housing.
So you have a massive population of deeply unwell people living their symptoms out in public.
Yes. And society becomes uncomfortable. The public demands that the police do something about the person acting erratically on the corner.
Right.
So officers frequently arrest individuals with mental illness for incredibly minor misdemeanors, trespassing, loitering, public nuisances.
Not because the person is a violent criminal mastermind, but because the officer literally doesn't have any other tool to get them off the street.
In many cases, the arrest is a desperate, misguided attempt by law enforcement to rout the individual into an institution where the officer hopes they might get fed and evaluated. But a jail is not a therapeutic environment.
Far from it. And the tragedy is compounded by how the public perceives this. The media constantly broadcasts narratives linking mental illness to horrific, violent crimes, creating this archetype of the dangerous, mentally ill predator.
But the clinical and statistical reality completely demolishes that narrative. Individuals with severe mental illness are exponentially more likely to be the victims of violence, sexual assault, and trauma than they are to be the perpetrators.
So we are taking the most victimized, vulnerable members of society, locking them in cages because their untreated symptoms make us uncomfortable, and putting them in an environment, jail, where their trauma is guaranteed to be compounded.
It is a horrific cycle.
Which is why there is a massive push for decarceration, reducing the prison population. But this presents a new paradox.
Right.
If you release hundreds of thousands of incarcerated individuals with serious mental illnesses, they must be absorbed by a community mental health system that, as we already established, is fundamentally broken and underfunded.
So the solution isn't just opening the prison doors. The solution is stopping them from going in the first place.
Are there actual interventions happening at the street level to break this pipeline?
Yes, progressive communities are utilizing pre-arrest diversion tactics. They are creating mobile crisis services that are directly linked to police dispatch.
So instead of a squad car, a social worker shows up.
Or they show up together. When an officer encounters a mental health crisis, trained mental health professionals arrive on scene to de-escalate the situation and physically divert the individual to a psychiatric crisis center rather than a booking precinct.
And if they do get arrested and end up at the jail, what then?
That is where intake screening becomes a matter of life and death. Implementing standardized tools, like the brief jail mental health screen, during the booking process can rapidly identify individuals who require immediate diversion to a hospital setting, rather than being thrown into general population.
Catching them before the gears of the justice system totally crush them.
Exactly.
Now, speaking of populations dealing with immense trauma and systemic intervention, we have to look at a group whose mental health struggles are inextricably linked to their service to our society, active military, and veterans.
This demographic requires an incredibly specialized clinical approach. We are looking at a population simultaneously managing complex physical trauma, traumatic brain injuries, amputations, chronic pain, alongside profound compounding psychological trauma.
The statistics are devastating.
Right.
Veterans experience significantly higher rates of major depressive disorder and PTSD than the civilian population. And the suicide rate is 1.5 times higher.
They are caught in a perfect storm of risk factors. You have the baseline trauma of combat exposure. You have a deeply ingrained military culture that normalizes high access to and proficiency with firearms.
Right.
You have high rates of co-occurring substance use as a coping mechanism, and you have the immense psychological shock of transitioning.
That transition piece is huge, going from a hyper-vigilant, heavily structured combat environment where your adrenaline is redlining every day, and suddenly you're expected to just mow your lawn in a quiet suburb.
The nervous system cannot just switch off. And from a clinical assessment standpoint, there are very specific nuances a practitioner must look for.
Like what?
For example, the sources highlight a high comorbidity between PTSD and OCD, obsessive-compulsive disorder in the veteran population.
Why OCD specifically?
Because the trauma of combat often rewires the brain to engage in hypervigilant checking behaviors. Because PTSD is so incredibly prevalent, high-yield clinical practice dictates that providers must routinely screen veterans for OCD.
Wow, I never would have made that connection.
Intrusive thoughts and compulsive checking can completely paralyze a veteran's daily functioning.
The sources also brought up an issue that is often swept under the rug, which acts as a massive threat multiplier, military sexual trauma, or MST.
MST is pervasive, and it is vital to recognize that it affects veterans across all genders. It is one of the most potent risk factors we see.
What are the specific risks?
A history of MST drastically increases the likelihood of a veteran developing severe depression, anxiety, eating disorders, chronic sleep disturbances, and ultimately suicidal ideation.
So when a veteran presents with all of this, the PTSD, the transition shock, potentially MST, how do we even begin to treat it? You can't just hand them an SSRI and tell them to come back in a month.
A purely biomedical approach will completely fail this population. The literature emphasizes that treatment must encompass therapeutic life changes.
What does that mean in practice?
It means treating the whole human, not just the diagnosis. It involves rebuilding their physical foundation through targeted diet and exercise programs.
Okay.
It involves actively teaching mindfulness, meditation, and stress management to help downregulate their shattered nervous systems. And importantly, it means providing a safe, guided space for them to explore spirituality and meaning-making after surviving profound trauma.
It is about helping them rebuild their identity. And obviously doing all of that, managing homelessness, diverting people from the justice system, rebuilding a veteran's life requires way more than just one doctor.
Absolutely.
It brings us to the concept of the village. We need to talk about the interdisciplinary team and specifically the role of the psychiatric nurse.
Modern psychiatric care is a team sport. The complexity of these systemic issues requires a deeply coordinated ecosystem of professionals.
So who exactly is sitting around the table in this multidisciplinary team?
Well, you have the psychiatrist, who holds the primary responsibility for diagnostic evaluation and prescribing medical treatments. You have the clinical psychologist, who conducts intensive psychotherapy and interprets complex cognitive and psychological tests.
And the social worker.
Right, the psychiatric social worker, whose focus is primarily on family dynamics, securing community support, housing, and navigating the entitlement systems we discussed earlier.
And then you have the professionals focused entirely on how the patient actually lives their daily life. The occupational therapists and recreation therapists.
Yes, the occupational therapist focuses on rehabilitating practical, psychomotor skills and activities of daily living. The recreation therapist addresses a crucial vulnerability, unstructured time.
Which we mentioned earlier.
Exactly. They teach clients how to constructively manage their leisure time, balancing work and play. For a patient with severe anxiety or schizophrenia, an empty, unstructured afternoon is a massive trigger for symptom exacerbation.
You also have vocational rehab specialists helping them navigate the workforce, and of course, the pharmacist.
The pharmacist is an indispensable safeguard. When you are treating a patient with refractory symptoms, meaning they aren't responding to standard protocols, or a patient taking 6 different psychotropics for comorbidities, the pharmacist monitors for dangerous drug interactions and severe adverse effects.
But right in the geographic center of this entire village, touching every single spoke of the wheel, is the psychiatric nurse.
The psychiatric nurse occupies a uniquely central, holistic space. Because their educational model encompasses both the hard biological sciences and the psychosocial sciences, they were almost always the ideal candidate to serve as the primary case manager.
They see the whole board.
Exactly.
Yeah.
A nurse can assess the trajectory of psychiatric symptoms, absolutely. But they're also trained to recognize when a sudden spike in anxiety is actually being caused by an underlying thyroid issue or poorly managed diabetes.
So they look at the whole body.
They evaluate the real-world bedside efficacy of the medications, manage the immediate side effects, and act as the primary translator, advocating for the patient across all those different agencies.
But the sources noted something deeply profound about what happens to a nurse's psychology as the system shifts. As care moves out of the controlled, locked hospital ward and into group homes, ACT teams, and clubhouses, the nurse has to undergo a massive philosophical shift in self-awareness.
This is arguably the most difficult transition for any healthcare professional to make. In a traditional hospital setting, the entire nursing model is built on the concept of caring and protecting.
Right.
Your primary directive is to protect the patient from harm. You control the locked environment to ensure absolute safety.
That is the baseline expectation of medicine. Fix the problem, stop the bleeding, keep them safe.
But as practice moves into the community, nurses must operate with intense autonomy, and they have to abandon the protecting model and adopt a collaborative model.
And what is the friction point there? What makes that so hard?
The hardest lesson to learn is that you have to let the patient make mistakes.
Wait, really?
Yes. As a client pursues full, actualized recovery, the nurse must allow them to make their own choices in the real world, even if the nurse knows clinically that it is a terrible idea.
Okay, I have to push back on that because that sounds like malpractice. It goes against every single instinct a medical professional has. You are trained for years to prevent harm, and now you're being told to step back, watch a patient make a destructive choice, and just let them fail.
It is agonizing for practitioners. It generates immense professional frustration and fear. But we have to ask a fundamental question about the nature of empowerment.
Okay.
If you constantly intervene, if you never allow a person to make a mistake and face the natural consequences, you're essentially keeping them in a state of permanent childhood. You are managing a symptom. You are not rehabilitating a human being.
The text from the source put it perfectly. The client can make mistakes, survive them, and learn from them.
Yes. That concept is called the dignity of risk. True recovery demands the right to try, the right to fail, and the right to learn from the consequences of your own autonomy. It is the exact philosophical opposite of the locked ward.
The dignity of risk. That is heavy, but it is deeply true. Okay, let's pull all these threads together. We have covered an immense amount of ground today.
We have mapped the entire macro system.
We started by looking at the institutional containment of the 1950s and traced how a few pills sparked a civil rights movement that emptied the hospitals but forgot to build the community safety net. We unpacked the modern paradox of managed care, where financial penalties drive incredibly sick patients through a revolving door.
We examined the reality of the streets, analyzing the poverty traps of SSI and the destructive force of NMBism. But we also looked at the brilliant innovations, ACT teams bringing the clinic to the park bench, the clubhouse model restoring autonomy, and the digital frontier proving that a 10-minute phone call can change a medical outcome.
We looked unflinchingly at the systemic failures, our prisons acting as asylums, the dual discrimination of homelessness, and the complex compounding trauma of our veterans. And finally, we looked at the dedicated interdisciplinary village required to treat the whole person, not just the symptom. It is a system that is deeply fractured, yet fiercely determined to heal.
And it all culminates in that fundamental paradigm shift, moving away from the illusion of a simple cure and dedicating ourselves to the complex, lifelong, messy process of recovery.
Exactly. So, as we wrap up this deep dive, we want to leave you with a final thought to mull over, something that challenges you to apply everything we've just discussed.
Think deeply about that concept we just covered, the dignity of risk. If a core requirement of true mental health recovery is having the freedom to make your own mistakes and fail, how do we as a compassionate society balance our intense desire to protect vulnerable people with their fundamental human right to live life on their own messy, imperfect terms?
It's a question without a clean, binary answer. It's not a broken arm on an X-ray. It's the complex, beautiful reality of being human. Thank you for taking this deep dive with us.